Good afternoon, and welcome to the Infection Preventionist series. What does the data mean, and what do I do with it? Conference call. My name is Zanera, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star, then 1 on your touch-tone phone. I will now turn the call over to Ms. Diane Dohm. Ms. Dohm, you may begin.
Hi, this is Tony Kettner from MetaStar. I'm going to be introducing your speaker today, but first I'd like to welcome you again to the second in the 6-part series on infection prevention and control. This particular webinar is focusing on what does the data mean and what do I do with it. So it's my pleasure to introduce Diane Dohm. Diane is a nursing home project specialist with MetaStar Incorporated, currently assisting Wisconsin long-term care facilities with enrollment in the National Healthcare Safety Network, or NHSN, reduction of C. difficile infection, antibiotic stewardship, and infection prevention and control. Diane is an HHS-certified medical technologist, has a bachelor's degree in business, and has been board certified in infection prevention and control since 2008. Diane is also a certified professional in healthcare quality. Diane, I'll turn the call over to you.
Thank you, Tony, and thank you, everyone, for joining us today. So our call today is really meant to be, again, a basic overview of concepts of infection prevention. It is not meant to be a substitute for completing the specialized training as required in Phase 3. We're still kind of waiting to hear what those requirements will be, but this will be a start. Just a reminder that you can put questions into the chat box during the call. We'll open up the call for you at the end to call in with any questions. And all questions and answers will be compiled after the completion of the entire series and made available to you on our website. Today's objectives: we're going to talk about how to analyze your data in a timely manner, to determine actions needed as indicated by your data, and to distribute data to the appropriate stakeholders. So what is data analysis? So as stated in the critical element pathway, infection prevention and control and immunizations, your infection prevention and control plan includes ongoing analysis of surveillance data and review of the data and documentation of the follow-up activities in response to that data. So as we're going through the webinar today, think about the data that you're presenting to your QA committee. Is it just numbers, or are you truly talking about the analysis of that data and your follow-up activities in response to the data? The documentation of that measure is often missed. Your facility data should really drive your program and your actions. It helps to prioritize your improvement efforts. It helps you to know how well you're doing. So we talked a lot on the last call about surveillance, and today we're going to talk about what to do with that data. But internally, you want to be comparing your current data to your past data. You want to analyze your data in a timely manner. So depending on what you're looking at, this might mean daily, monthly, or quarterly. Obviously, things like resident and staff illnesses you need to be following on a daily basis, and other items might be monthly or quarterly. So when we talked about that it was important to use both internal and external baseline or benchmark data. Internally, you're keeping track of your infection information on your infection log. You're comparing this month to the previous month to see what changes there have gone. But you also should be comparing it to external data. Probably most familiar with the CASPR data. You may also be part of a group or a corporation where you can compare your facility to other facilities within that group. In literature, you can check for long-term care data as well as the National Healthcare Safety Network. Historically, there has not been a lot of data, national baseline data for long-term care, but that is changing, especially for those of you that are putting in your C. difficile data. That will become part of the first national baseline. So what are you looking for when you're analyzing your data? As I said before, you're comparing your current data to your past data. You're looking for unusual or unexpected occurrences, sentinel or very serious events. We're going to talk a little bit about trends and clusters, and also how their data may indicate non-compliance with your policies or your protocols. Do you audit your processes? Is your infection data showing you that perhaps they aren't compliant, and is more education needed? All those, you're going to use your data to guide. So what is a trend? There are a lot of statistical terms, and we aren't going to cover very many today. We're going to just really stick to the basics. But a trend is really just a pattern of your data points in a time series of data. So you're used to seeing this type of a chart, typically called a run chart. It's just a visual representation of whether your rates are rising, falling, or remaining steady. A run chart typically has the number of events on the vertical or the y-axis, and usually time, in this case months, is on the horizontal or the x-axis. You can also place what we call a benchmark data line or a goal on your run chart, and even have a trigger line there so that you know that when your data crosses that line, it necessitates action. You might hear this referred to as a control chart as well. A cluster is really just when data is centered or located around a particular value, a particular location, a particular time. It might be on a specific floor or ward, or due to a specific provider. And if you're a smaller facility, you probably already know this without looking at your data in a chart. But when you're looking at a bigger facility or extensive data, it's nice to be able to look at this. You're also looking for, again, that increase in infections. Your surveillance process needs to really be able to identify that quickly so that you can take the appropriate action. So as you can see here is a sample graph of urinary tract infection rates, the number of infections over the course of a year. If you weren't keeping track of this and didn't go back until the end of the year, it's really not very helpful for you to try and figure out in December why you had the spike in May. So the goal is really rapid identification of those increases in rates so that you can take the actions needed to remedy it. You might have to review your process, your protocols. You might have to do competency testing or training of your staff to see where the problems lie. Two other terms that are often misused or switched around are prevalence and incidence. Prevalence is really just a measure of the total cases, so the number of cases divided by the total population. Incidence is similar but different. It is really the rate of the measure of the number of new cases arising in that population over a given time period. So in order to try and remember those, when you have incidence, it's new cases, so your two ends go together. And if we go back a slide, and you're talking about prevalence, it's the amount in the population, so your P's go together. It's the trick that I use to keep it straight. Really just incidence equals new. If your data shows a very large spike, or you have a sentinel or a serious event, you might need to do a root cause analysis or an RCA. The goal of that is really to focus on the system issues rather than placing blame or trying to decide who screwed up that it had occurred. You're really looking at what can be changed in your system or your process to prevent it from happening again. And there's a great resource listed there. Be sure to follow up on the issues that you identify when doing a root cause analysis. You may have to audit if the changes that you make to a process to make sure that they're actually occurring and that they stay over time. Often there's backsliding back to old processes if you're not auditing that. Your surveillance, your data may also show changes in the prevalent organisms or the most common organisms that you're recovering from your cultures that you're sending in on your residents, or changes in your resistance pattern. So for example, E. coli causes about 40% of the urinary tract infections for long-term care. If you start to see a big change in those pathogens or you see an unusual pathogen, that's also a trigger point that you will have to look at to see why that's occurring. You also want to be following your resistance patterns, so when you get your culture and sensitivity reports back from your microbiology lab, so for example, are you seeing more methicillin-resistant Staph aureus or MRSA? Are you seeing CRE? Are you seeing generally an increase in a class of antibiotics such as quinolones that may indicate that that class of antibiotics is being overused? Now, as we all know in all of our states, CRE triggers a very specific response, and your health department will have links to that at the end as well in our resources. But your public health department has very specific guidelines to follow when you have a CRE positive resident. Your data, as I said, drives the actions needed. So what you want to make sure of in your infection prevention and control plan is that that process is identified. So what threshold or trigger should signify an action that has to be taken? You want to make sure that that's very clearly identified in your infection prevention and control plan. So what is it that you need to do when you reach that threshold? Who needs to be notified? How quickly? Your medical director, your quality assurance committee, division of public health. And this is somewhat unique to your organization based on the risk assessment that you're doing, but you want that spelled out in your infection prevention and control plan. Once you identify an infection control issue or concern, it falls to the IP to start investigating that and to start looking for recommendations for corrective action that might be needed. This can include short and long-range planning of educational activities. You have to prioritize your actions. But this is part of what you as the infection preventionist should be taking to your QAA committee for discussion by the interdisciplinary group, versus just taking them the total number of infections that you have each month. We're going to talk a little bit more about that. So who do you present your data to? Again, this can differ a little bit from facility to facility depending on the structure. But certainly you're taking it to your governing board or your board, to the Infection Prevention and Control Committee, or if you're calling it your Quality Assurance Committee. And are you a member of that committee, or are you just sending the report? One thing to keep in mind, when Phase 3 implementation of the final rule states that the individual designated as the infection preventionist must be a member of the facility's Quality Assessment and Assurance Committee and report on the infection prevention and control plan on a regular basis. So that goes into effect, as you know, November 28th of 2019. But you should already be part of that committee. Again, you're taking them relevant data, so not just the total number of infections, but very specific increases in a certain type of infection, perhaps inappropriate antibiotic usage. It needs to be actionable data, so changes from your baseline. You're going to be talking to them, letting the committee know what you've already done, so already actions taken. What additional actions are you planning? What do you need their assistance or guidance for if you're talking about system changes? This is what your Quality Assurance Committee should be discussing and deciding. Who else needs your surveillance data? So it's important to get that data to your medical director and to providers. They're interested in what your infection rates are. You need to be giving them your antibiotic utilization information. Your staff should also have access to knowing what your infection rates are, what your compliance with hand hygiene, perhaps personal protective equipment usage is, what your audits are showing. And some facilities even include their resident counsel when appropriate. So perhaps they're involved in your hand hygiene compliance program. But at a minimum, be sure that your medical director, your providers, and your staff get to see this data. So once you determine what information you need to give to these folks, you also think about what's the best way to disperse that information. Again, will depend on your facility and your setting. Is it in a provider newsletter? Is it at staff meetings? There are facilities that will display infection rates in a graph that are in staff areas so that your staff is aware of what you're seeing. But often really multiple methods are needed to get the information disseminated. It's great that you know it, you're taking it to your quality assurance community, but be sure that you're also disseminating that data to others that might need it. So our next call, which will take place on March 6th, we'll be talking about outbreak recognition and management. See the link there. Some of the resources that I used to put this talk together today, you'll find APIC has a great long-term care association for professionals in infection control documents on our Lake Superior Quality Innovation Network website. And to get a certificate of attendance, that link will be placed in the chat box shortly. So when you complete your evaluation, you will receive a link to the certificate of attendance. Please print that and put that into your education folder. Again, until we really find out what the surveyors will be looking for as to proof of infection prevention specific training, you want to keep certificates to any training that you've been attending. We'll open it up for questions. You can place them in the chat box. First thing I see is how do I get back to this PowerPoint at a later time? The PowerPoint slides will be available on our website as well as the Q&A once our series is finished. You can also email those questions to me if you have them after today's meeting, and we'll have the operator remind us how you can call in with a question.
Thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a slight delay before the first question is announced. Once again, if you have a question, please press star, then 1 on your touch-tone phone. Waiting on standby for audio questions. And I'm not showing any audio questions at this time.
All right, so while you're compiling any questions that you might have, we'll take a few minutes and answer some of the questions that we didn't get to on our last call about surveillance in general. One question that was asked, if they were interested in whether you group all the antibiotic cases in one section and including fungals in your monthly report. Should I even be tracking antifungals? I would say that for antibiotic starts and antibiotic usage, typically fungals are not included in that. But if you see that there's an issue in your facility, it's something you can certainly talk to your medical director about. Typically, antifungals are not included in your antibiotic start data. Another question that we had talked about somebody was looking for information and resources on safe food handling to be able to teach their nursing assistants when they were serving the food trays. So one of the places that I looked for that is if you go back to the training materials that are used for the CNA program in your state. In Wisconsin, we can get access to that manual, if you will, free of charge. So look to see whether that's possible in your state. They have a very nice chapter on how your certified nursing assistant should be handling food serving, assisting with eating, etc. So I would guide you to that resource. One of the other questions from last week, they were looking for a link to the risk assessment that we talked about when you do your facility risk assessment. The CDC has one on their website, so I will have that link as well in the Q&A. A question also came in last week asking, is it acceptable to assume that the percentage is listing with the Antibiogram? So they were asking whether your sensitivity value should be above 80% to be considered efficacious. And that is not really the way you want to look at your sensitivity report. Certainly your medical director, your pharmacist can give you more information on that. But it has to do with the type of antibiotic that you're testing, what the route of administration is, what your resident, factors might be, such as renal clearance. So it isn't really that clear cut that you can say, well, if my sensitivity is above 80%, I should be able to use that antibiotic. So I would suggest working with your laboratory and your pharmacist to really evaluate that question. The question came into the chat box. Do you document viral trends or only those requiring antibiotics? So typically, we mentioned last call on our infection log, you would track especially your respiratory illness as well as your GI, whether it's caused by viral or bacterial. There's a question whether they could ask about a specific precaution question. You can go ahead and put it in the chat box, and if we have time, we'll answer it. Otherwise, you can also email it to me. So we have a question in chat. In counting infections, according to McGear's, in order for a true UTI to be justified, both criteria 1 and 2 must be met. If a resident does not exhibit any symptoms, as in criteria 1, but the lab test comes back positive for a UTI, are we counting this since both criteria are not met? So again, this would not meet the definition for McGear's. It would not be considered a urinary tract infection. That resident may well be colonized with the organisms that you're recovering from your culture. Again, we would want to look back at that case. If they were not symptomatic, why did we take the culture in the first place? So always good questions to kind of be looking at. So the magic question I wish I knew the answer to, what education should we be pursuing for those phase 3 requirements for conditions of our participation, a final rule? We don't really have the details yet. I would say a couple of things as we talked about, make sure that you're keeping your certificates from any education that you do attend. Joining APIC, Association for Professionals in Infection Prevention and Control. While I don't know whether that will be required to fulfill that stipulation in phase 3, it certainly is a great step. Once you join National APIC, you have at your fingertips a multitude of resources online that you'll have access to. I would also suggest joining your local chapter. That's where you will find your support network, if you will, especially for long-term care. Do some great benchmarking there against other facilities. So I would definitely suggest joining APIC as well. And we'll certainly pass along any information we get once it becomes available on what they'll be looking for as far as meeting that rule. So we have a question, if a resident who is C. diff positive has an ileostomy, do we need precautions all the time or just when doing cares on the ileostomy, such as changing bags? So when you think about whether your resident needs to be on precautions, and we'll be talking about that in one of our next calls as well, one of the things you look at is, are they still symptomatic? Are they still on treatment? So often this is a resident assessment that you're doing, so you certainly would want to be using precautions when you're caring for that ileostomy site, but they may always have loose stools, and that resident may be down the road colonized with C. difficile. So again, you want to do the resident assessment. And as I said, we'll be talking more about that in one of the following webinars that we'll be doing. So this was a response to our question about if the patient wasn't symptomatic, why did we do a urine culture? And as often the case, the patient exhibited confusion or delirium, and so they prompted doing a UA and a CNS. And while I think that a lot of providers will still do that, we do want to try and educate them when you can that if the resident isn't symptomatic, that maybe you want to be watching, doing some watchful waiting on that resident before we do a UA. As often many of our residents will give you a positive UA or a positive culture and really not have a UTI. That can also really be a cause of inappropriate antibiotic use. So something to think about there. When will the previous training, meaning our first call 2 weeks ago, be available on YouTube? I'm thinking you'll see that first one quite soon. As far as I know, they'll be coming up as they get done. So I would say in the next couple weeks you should see that being on YouTube, and the link to that will then be posted on our website as well. And operator, do we have any questions on the phone line?
Once again, if you have a question, please press star, then 1 on your touch-tone phone. And I'm not showing any audio questions at this time.
Thank you. One of the other questions that came in after the last call was if my infection rate is 7 per 1,000 elder days, is that an acceptable level? So as we talked about, giving just a raw number of total infections is really not indicative of being useful data. You don't really know what to do with that because you don't know what type those infections were. Did you have an increase in a certain type of infection like a urinary tract infection or a respiratory infection? So you really want to make sure that you're giving useful data. So rather than just lumping those together, I would say once you look at your log and you know your data, you're going to be giving your, whether it's a QAA committee, you're giving them the increase in say, your top 5 types of infections, rather than just a total raw number. You also really cannot benchmark, whether it's nationally or with other facilities. And so that's why you don't want to give them just a number. It's often much more helpful to separate your infection types, and that way you can compare your facility data over time. You know, was it your UTI rate that's causing the increase in that number? 7 by itself really doesn't mean anything. So we do have a note in the chat box that the webinar vendor is having technical issues with our first call, so that will be coming. The slides for today were available. The link is in the chat box, as well as when you registered for the webinar, and on our website you should still be able to find those as well. There really isn't a way for you as a listener to print out the chat conversation, but I will tell you that that's something that I look at afterwards, and that will be part of the Q&A. So there will be a cumulative Q&A from all 6 of the sessions put together and distributed when our series is over. Any other questions or comments that you have on today's webinar? What to do with that data? Who do you give it to? How to compare it? You can either put those in the chat box or use the phone. The link to the slides has also just been put into the chat box for you. We do have a question in chat. With the McGear's criteria, with and without indwelling urinary catheters, change in mental status is criteria 1. For catheters, but not for without catheters? Is there a reason why mental status changes is not included for those without catheters? I think this is why your physicians are ordering UAC&S. Honestly, I cannot answer that. I would have to go back and look at the McGear's criteria and the panel of folks when they put that together. Often when they write a document like that, they will put in sort of what their reasoning was. So I will see what I can find out for you there and put that into the Q&As as well. Are there any good software programs out there for recording and presenting IC data in a useful way? I feel like there's a lot of data and spreadsheets require a lot of time to make charts and the like. Not that I know of, other than, I mean, you can certainly make some pretty easy charts and graphs from Excel if that's how you're doing your spreadsheet. If your spreadsheet, your infection log is manual, it's just a piece of paper, that's not going to be as easy. But I think just basic Excel, if there's anybody in your facility that knows how to use that, even if you haven't, become comfortable with it yet, that's a really nice way to show your data over time. Some of those first slides that I showed you with the run charts, etc., those are easily made out of Excel. So I would say try and find somebody in your facility that's comfortable using Excel. Or I hate to say, even just looking it up on a YouTube video is probably the easiest way to do that. But I'm really not familiar with any software programs other than that. Are there any other questions that we can help you with today? Operator, do we have any questions in the queue? I'm not hearing any questions. I will give you back the gift of time. I encourage you to register for our third in the series webinar coming up. As you close out of the webinar today, you will get a link for the evaluation. Once you complete the evaluation, you will get the certificate of attendance. Again, thank you for joining us today, and I hope that we will see you back for our third webinar. Thank you very much.